She's a surveillance medical officer, Puducherry and WHO India, supporting Puducherry as well as in Tamil Nadu government in vaccine preventable disease surveillance and routine immunization, strengthening around 25 years in public health. She has received Dr. MGR Gold Medal in Community Medicine. Over to you, madam.
Good morning, ladies and gentlemen. I think, first of all, hearty congratulations to IAP and especially the Tamil Nadu chapter and the organizing committee for riding high on rationalizing and resurrecting clinical pediatrics. I can see a lot of people having a disinterest in this topic and moving out. I think the oration is only at 11:45. I will request some of you to stay back simply to understand how the country is poised today when it has been driven by a very, very important aspect of how pediatrics has shaped a healthy child. So over to the topic, please. So my presentation would touch on what is the current universal immunization program in the country today, and also what is the progress on the VPDs, and especially focusing on the operational components of the program. I would thank Dr. Winsley Rose for setting the stage when we talked about surveillance. I will refer to that when I come to the topic on surveillance. So on the universal immunization program, we all in the country need to feel very proud as we have one of the largest cohort of children that are immunized at any point of time. This is both the public and the private sector, and immunization has been the cornerstone of pediatricians. You have driven the program to where it is now. Of course, we have the maternal immunization where we have antenatal mothers as many as 29 million immunized over a particular point of year. And then we have also, the program has grown so much that if you see in the recent times, we've had a lot of vaccines that have been added to the program. I would like to draw your attention to the current immunization schedule. I know that, under the IAP, we have an alternate immunization schedule. That is for the sector of people who can afford the vaccines. But you can also see the universal immunization program has added to its bounty a basket of choices and availability for the young infant. So we have the PCV, which is the latest addition into the program, and the JE vaccine, which used to be a live vaccine in Tamil Nadu and not administered in Pondicherry, at least in the endemic districts of Tamil Nadu, has recently been moved to having an inactivated JE vaccine given at the same period of 9 to 12 months and 16 to 24. This information for you is very important simply because you may have people who have received this vaccine, and also Government of India has a plan in how the vaccine has to be administered, in terms of choosing the site and limb. When you look at any adverse event following immunization in your clinics, you would be able to, correlate this to the kind of vaccines that the child could have received at a particular point of time. In addition, we have excellent planning when we say in terms of the cold chain and storage and how vaccines need to be stored in an ILR. And now we also have the, front door ILRs that have come in recently into the program. Sometimes, there are some positive trade-offs of the COVID-19 program. So a lot of ILRs have reached the program. So we have this. And in addition, the sequence of immunization. Now, the sequence of immunization is very important because this is evidence-based. It is that, you give the least painful, the oral vaccines first, followed by either intradermal or subcutaneous. Here in this instance, the fractional IPV, followed by the injectable vaccines. So this is how the program is evolved. And of course, the milestones could not have been possible without, the support by the trailblazing of pediatricians who have been able to support and lend a voice and hand to the eradication of polio and also maternal and neonatal tetanus elimination. But has the pandemic impacted immunization in the country as it has in anywhere, in especially the third world countries? a huge yes. India, though, has not had a very significant drop, I would say, from 91% to 85%. India, in terms of absolute numbers, has a huge cohort of 3.5 million children who, and in this way, we seem to be top on the list, unfortunately, of unprotected children. And the NFHS 5, the NFHS 5 data corroborates to this, especially the phase 2 districts and states. Now, what is also significant and what needs to be looked into is what antigens have not been administered. Very interesting, especially, of course, that hepatitis B birth dose has been given, but what also the children have had missed opportunities are for BCG, for DPT 1 and 3, and there is a significant drop between DPT 1 and 3, which is a very important surrogate and a proxy to say how our immunization programs are running. And we have within the country some of the states who have had huge numbers of missed children. We've had Tamil Nadu also on the list, as well as Pondicherry. Pondicherry has about 7,000 and odd children who have missed the vaccination as a result of the pandemic. But in Tamil Nadu, you can see that we have about 1,72,000 children who have missed out on their DPT-3 at the appropriate time. Now, that's a huge number to understand and reconcile to. And the impact of it would be in how we look at surveillance of vaccine-preventable diseases. That said, again, Tamil Nadu has scored well in the NFHS 5 and in all the antigens, but for those of whom who are in Pondicherry, you can see that there is a slide in the NFHS 5 data which says that also, is a harbinger for intensive campaigns or catch-up campaigns. The intensified Mission Indradhanush 4.0 is to roll out in the subsequent months. So, on one side, immunization is important, and we've all been, very instrumental in driving this immunization towards a healthy child. But how do we measure that our immunization works? Is it that our program is working, our vaccines are working, or is it something that is not in place? So that is where our disease surveillance falls in place. Quickly, in the next 8 minutes, let me just walk you through what are the updates in each of this. Now, I have put the MR surveillance, the measles, rubella surveillance, over the AFP surveillance and the lab-supported DPT surveillance. The lab-supported DPT surveillance is new, but the MR surveillance takes into context a very new connotation, simply because measles and rubella as diseases need to be eliminated as per the Southeast Asian region goal. So we have what is as the rechristened fever rash surveillance. So India is mandated as a part of the Southeast Asian region to eliminate measles and rubella by 2023, which means we have to bring down the incidence of measles in our country. Not just that, we will have to demonstrate, like what we did in polio, a non-measles, non-rubella discard rate, which means we have to report all cases with fever and rash and be able to categorically say, this is not measles, this is not rash. Now, this is the most important part of the surveillance. Now, the fever rash surveillance is the strategic objectives we looking at is to have a 95% coverage of any measles rubella containing vaccine. So we have either it is MMR or MR, which is given in the Universal Immunization Program, and we also have what is called as a case-based surveillance. So that is very, very important. And of course, we have lab setup and pandemic preparedness. This is to show you Southeast Asian region has 11 countries, 5 of whom have managed to eliminate measles, 6 of whom have managed to eliminate rubella. We are not in either of the lists, but we soon need to get there, and we have 1 year to go. So what do we need to do that? India should reach a non-measles, non-rubella rate of 2 per lakh population. So how does one do that? So it requires that we report all cases which resemble measles and rubella. Now, what has also been redefined in this definition is, we looked initially at reporting fever with rash and one of the 3 C's. But that definition has been revised by the Government of India to have what is called as a fever rash surveillance, which means we have to report cases in any person across all age groups with fever and rash. Now, why this is important and why I was making a reference to Dr. Winsley Rose's presentation this morning is, for those of whom who might have heard it, all those differential diagnoses that he was talking about in terms of scrub typhus, spotted rickettsial diseases, dengue with rash, all those need to be reported. How many of us are actually making an effort to report that? Of course, you know the clinical diagnosis, but here we are to report any fever and rash and bring a lab confirmation to say that it is neither measles nor rash. The understanding of the definition of surveillance is extremely important, and only you can, as pediatricians, drive this forward to help India achieve the measles rubella elimination goal. So, looking at it, how do we do, or what do we do in the program to say that it is not measles or rubella? We collect either serum samples over a period of 28 days or throat swabs or urine samples for culture for genomic sequencing of the measles virus. So that will enable the program to either confirm measles or confirm rubella. The reason why I wanted to bring this lab component here is, many a time I have seen in the medical colleges here in Puducherry, and I also incidentally happened to extend my support in Tamil Nadu to 9 districts, or rather 10 districts in Tamil Nadu up to Trichy. So what happens is that we see that even as recently I've seen people sending out samples for measles confirmation to the private labs. There is a system in place. All suspected measles cases, all suspected with fever and rash itself needs to be reported, and there is a flow of activity that flows from the district offices or the state government offices. So the King's Institute of Preventive Medicine in Chennai, in Ginty, is the designated nodal lab which is WHO accredited and supported by the Government of India for saying whether this is measles or rubella or otherwise. Now, there is no need, I would like to reiterate, to send the samples to a private lab. Of course, the tests are done free here. And apart, not just this, we also do a genomic sequencing. Cases have started being reported from other parts of the country. This is India. And you can see Tamil Nadu and Pondicherry are yet to warm up to fever rash surveillance. Unless we get there to understanding the concept and reporting and saying no, at a sub-national level, we would never have achieved the measles elimination. Tamil Nadu led the country when it had to eradicate polio, and the country also looks up to a state which is very strong in its public health and private infrastructure to be there on the top. You can see most of the districts in northern India have reported suspect measles and rubella cases. Mind you, these are not cases of measles or rubella. These are fever and rash reported to a surveillance system. We've not yet warmed up to the idea. Right. So when you look at the epi curve, we see measles lab confirmed is a small number, understandably so. There cannot be too many cases of measles now, especially after we had a very robust MR campaign in 2017, and the public health program has a MR vaccine of 2 doses, and the private sector has already been given MMR for a very long period of time. And similarly so, we have a significant number of rubella cases, not clinically diagnosed. Clinical diagnosis, you don't even see that legend there. Most of the cases that are reported as suspect measles, or not most, all the cases of rubella that have been reported as measles have been lab diagnosed or epi-linked as rubella. That said, obviously, the vaccination status, wherever the vaccination status has been staggered or incomplete, there the measles has been higher. And you can see this is a very important recent addition to understanding how there has been an epidemiological shift. After the MR vaccine that has been introduced for the last 5 years, we have seen that measles used to be in an older cohort, like 10 to 14 years, but you can see now we have measles in children less than 1 year and children between 1 to 4 years. Interesting. This is the lab-confirmed measles cases we are talking about. And then also and in a similar fashion, we have rubella cases between the less than 1 year and the 1 to 4 years. So that said, what are we looking for? We are here trying to break the indigenous transmission of the measles virus, which means we are looking to try and find out what are the genomes that are driving this transmission. And as you can see, the D8, measles has 30 genomes and one serotype. So of those, there is one genome which was the D8, which was significant, and you can see that that number is coming down. So we are that close to measles elimination and rubella elimination. So that is very, very important. And you can see in the country, because we have not contributed too much towards the reporting of cases. If you look at 2021, 23,000 suspect measles cases have been reported, and almost 75% are negative. That's how we want it. We want to say we are close to measles elimination and rubella elimination. So India has reached a non-measles, non-rubella rate of 1.5. But when you come to Tamil Nadu, we don't seem to have those numbers. We need to really improve on our surveillance. This is just to say we need to get our concept right on what is to be reported to the fever rash surveillance. So quickly, again, we'll use the next 3 minutes to talk about the lab-supported DPT surveillance. Tamil Nadu started the lab-supported DPT surveillance in 2019 and Puducherry in 2020. The reason or the background is we did have a lot of cases in 2017 and 18 of diphtheria, but none of these were lab confirmed in the standardized protocol. So the Government of India has initiated a lab-supported DPT surveillance across the country. 25 states are now reporting to the Government of India in a systematic form with EPID numbers. But as you can see, we do not have too many labs. We have the State Public Health Lab in Chennai, which is the DPT lab, and JIPMER is the lab for Pondicherry. In addition, we have CMC Vellore. I'm only talking about the south, and especially in Tamil Nadu and Pondicherry. CMC Vellore is the reference laboratory. We have only 2 reference laboratories in the country. So what do we report? We report cases of diphtheria, and you should see, this is very important, that you can see a sizable number of diphtheria is happening now in the younger age group. The same slide 3 years back when I had the pies on 2017, 18 and 19, we had more adolescent diphtheria. But now you can see more younger cohorts having the diphtheria. In addition, of course, unvaccinated, the chances of getting diphtheria is higher. So whom are we reporting? Which is why I was again making a reference to the presentation by Dr. Rose. So we're talking about a membrane here in addition to the inflammation. So what does the program do? The program picks up 2 swabs which are sent to the State Public Health Lab in Chennai. Similarly, so for pertussis, we do not have too many cases reported, at least in this part of the country. The definition looks at reporting a case with more than two weeks of cough. And here what we do, we have a huge window period, 12 weeks enough to be able to collect a serum sample or 2 nasopharyngeal swabs within 4 weeks. Now what we do is, what was difficult and challenging in the program was being unable to culture these organisms because they are fastidious, as you know. So what we are doing is using Amy's transport media, the logistics support, which is available in the labs. And neonatal tetanus, as we all know, is not seen, eliminated, but then you have to be familiar with what is the global and the definition that is followed in surveillance across the country. There are no laboratory diagnostic tests available. So what really happens is the cases have to be reported to your district to the DDHS offices in your districts or the DIO, the district immunization offices in the other parts of the country. And we have the acute flaccid paralysis, which is the major program on which the other were rising. Here I just want to say a few things because I'm running out of time. I just want to say we are only one region now in the world anywhere to have polio, and that is the Eastern Mediterranean region. At the moment, we have only 5 cases across the globe. Now, this is as close as we get to immunization. I'll quickly wind up by saying that we do not have VDPVs, but the world has a lot of VDPVs, and we need to remember that this is a slide I want us all to see before I conclude, because I'm on time. I just want us to remember all these cases merit reporting for acute flaccid paralysis, surveillance, not just the typical GBS or traumatic neuritis or transverse myelitis. Reason being, while polio virus could have been detected when we had polio in all these instances, and similarly so, we should be able to pick up these cases. I would like to conclude by saying that, immunization has the travails of traveling through a lot of difficulties, but, with a very strong public-private partnership, southern states have made giant strides, and we've been able to keep a very, very healthy cohort of children and have had a huge, impact on the healthy children. But as I mentioned, 172,000 children have missed out immunization in Tamil Nadu, and I think that is going to reflect in surveillance as in the coming days, as was rightly pointed out in the previous presentations. So I leave you with this, and with also the concept of a measles and rubella elimination goal with reporting of any fever rash to the program. Thank you very much for the opportunity.
Thank you, Madam. Thanks for your vivid presentation on vaccine preventable disease and surveillance. Do we have any questions over the floor? Madam, I had happened to work in Southeast Asia for 6 years. So as you had mentioned about measles and rubella surveillance in these 2 Southeast Asian countries, it's less. So I was in Brunei for 6 years, and we have not seen much of rubella and this thing. The reason is, I was in the public health also. So we used to have MMR vaccination to be done around 7th standard to 8th standard there. So because of that reason, we could not get much of these cases. Adolescents, measles and rubella vaccines were given for children around 7th to 8th standard, that's Form 1 and Form 2 there. So we don't see much of those kind of cases. Is there any possibility of those kind of things happening in India?
Thank you so much for asking that and also enlightening us on this aspect. See, this is how immunization programs are driven. Policy decisions are made in immunization. If today TT vaccine has been replaced by TD vaccine, it has been because of the need that has been felt for, diphtheria as a disease. So similarly, when you see a shift from the younger cohort to the older cohort, then you know that there will be a need for an MR vaccine as an additional dose. So that is how policy decisions are driven. But as you can, we know it's a huge program. So may not be, easy to take it immediately on the pallet, but it will be driven by how the data pans out.
Any questions to the floor?
If there are no questions, I request the chairperson to hand over the memento to our speakers.
Thank you.
Dr. Aruna Rajendran.